Is there a difference between undifferentiated and like not well encapsulated?
So those are totally different things. Yes.
Okay.
So differentiated has to do with how do the cells look under the microscope, right?
eShadowing with Dr. Julie Krystal.
Hello.
Pediatric oncologist. How are you doing, my friend?
I'm doing okay.
Usually when I say my friend at the beginning of these, like I just say it like, they're my friend. But literally, like, we went to med school together.
I am cool enough to say that I went to med school with you. As we just said, you're such a celebrity. Like I can say that I knew you way back when.
I have another friend from internship, Dr. Shireen Idris, who's like super famous dermatologist in New York City. It's like that for me. Like, I know
totally.
I know.
I knew you.
No, I'm not that famous though. We're going to talk about pediatric oncology.
It's such a great topic.
It is a great topic. So good that I'm having you back because you were on Specialty Stories with me.
Yes.
And now you're doing eShadowing because all the kids love coming on and seeing cases and hearing from the physicians live and learning. And with COVID, shadowing got shut down at most places. And so this is a second best alternative.
I'm excited.
I guess. So let's start with our favorite question here. What is bread and butter pediatric oncology? Which seems kind of oxymoronic, like none of that could be bread and butter, but I'm sure there's a lot of bread and butter still.
So there are things that are considered bread and butter, and those are the things like leukemia, which is the number one most frequent, oncology diagnosis. So that's considered pretty bread and butter. Everybody should know how to take care of that, right? So leukemias and lymphomas. And, the other things that are really bread and butter are some of what we call benign hematology, which is blood problems that don't have to do with cancer. So things like iron deficiency anemia and neutropenia and some very general problems like that are really considered sort of bread and butter. And then there's a whole lot of very rare and more unusual diagnoses that become, much more complicated things.
Yeah. So right off the bat, you talked about some hematology. I had introduced you as a pediatric oncologist. So people are confused right now.
Yes.
Hematology, oncology, very common kind of squish them together specialties.
Oh my gosh. Can I show you my slides? Can I show you my slides? I have a whole slide about this. I have a slide about this because this is, wait, hold on. Turn screen share. Okay, hold on. I literally made a slide about this because this is such a common thing. Okay, wait, hold on.
We'll make it work. We'll make it work. Come on, Gmail.
It's a lot of pressure for Gmail.
Got it. All right. Let me download. Are there any like fancy animations or anything?
No.
Awesome. All right.
No, so I'm clearly not that technologically advanced.
Awesome. All right. So I'm going to do it the old fashioned way and put it right in. We will get going. All right. So as that's going up, what's your favorite memory of Valhalla, New York at New York Medical College?
Of course, it's the station.
Of course, it's. I was hoping you would say the station.
It's karaoke at the station. I mean, I have so many. I loved medical school so much. Like it was. People think like, oh, it's like stressful, whatever. Like it was so freaking fun.
It was fun.
And like karaoke at the station. There's just like nothing else in my life that really had that.
Yeah.
That feeling.
Yeah. It was fun. I tell students that all the time. Med school is busy.
Yeah.
It's kind of hard.
Yeah.
It's just a lot.
But it's so great.
But you just meet the best friends. And it's so fun. All right.
So here it is. Pediatric hematology, oncology, and cellular therapy. We're going to talk about that as too, and why you will love it, because you will. So as Ryan said, I'm a pediatric oncologist. I'm also the fellowship program director for my hospital. And my other work that I do is in early phase oncology clinical trials. And I'm happy to talk about that a little bit too. So what is it? So the word pediatric means kids, but contrary to that, we actually also take care of adolescents and young adults. My oldest patient was 28, 29, and that's because he had a pediatric tumor, right? So adult oncologists don't know what to do with certain kinds of tumors. So even though someone is 28, they send them over to us. Hematology means disorders of blood. So you can have problems with red blood cells, and that includes things like hemoglobinopathies, which is the fancy name for sickle cell disease, and other problems with your hemoglobin. You can have enzyme problems like G6PD, things like that. You can have problems with your white blood cell, problems with the structure, problems with the function, problems with the number of them. You can have problems with your platelets. You can have too many, you can have too few, or you can have a problem with how they function. And then also under the category of hematology is all the problems of coagulation and bleeding, which are numerous and many. And I'm not a fan of them, but there are people who specialize in that, and like that's their jam. The coagulation pathway, they love it. That's their thing.
Ew, blood.
Ugh. All of that falls under hematology. That's all disorders of blood. Okay. The word oncology, that part means cancer. And there's a few different kinds. So leukemia and lymphoma are typically called the liquid cancers. Solid tumors include things like neuroblastoma, osteosarcoma, Ewing sarcoma. We'll chat a little bit. And then neuro-oncology is often given a separate category, and that's tumors of the brain and spinal cord, things like medulloblastoma, diffuse midline gliomas, and gliomas. And now we call things cellular therapy instead of bone marrow transplant because it includes bone marrow transplant, but also CAR T cells and gene therapy. CAR T cells are super, super awesome. It's a treatment that has completely changed, all of the things for leukemia. Kids who are not curable are now curable. Basically, in a nutshell, we take your T cells out of your blood and we modify them with a little receptor that's on your cancer cells. And then we give them back to you and they go in your blood and they attack your cancer cells and they get rid of your cancer. It's like mind blown, super amazing. And it works. And that's the craziest part. It actually works. So all of that falls under cellular therapy. So all of these things technically fall under pediatric heme onc. That's like one name that encompasses so many things. All right. So what is the training like? These are some various pictures of me during training. So everyone has to go to medical school. Then you have to do a pediatrics residency, which is 3 years. Then you have to do a pediatric hematology oncology fellowship, which is 3 more years. That's all ACGME approved. There are now sub fellowships that many fellows do, and that's an extra 1 year. So like an extra 1 year of brain tumors, an extra 1 year of CAR T cells, an extra 1 year of coagulation, whatever. These 1 year bonus training things are not ACGME regulated. Yeah. But a lot of fellows are doing them now. So just like I thought med school was awesome, fellowship was also super awesome. All these pictures are me in fellowship. This is probably the only time I was really suffering, when I was like super pregnant and on call and hadn't slept in a long time. But, it was really great. Fellowship was a ton of fun. I did research. I met awesome colleagues. You learn so much. The clinical training is just so steep that it's all really rewarding and awesome. So at the end of all of that, you come out and now you're a peds hem-onc doctor. So what do you do when you're a peds hem-onc doctor? There's a lot of different things a career can look like, but vast majority are hospital-based. Private practice peds hem-onc does not exist. And the reason is because pediatric cancer is rare and all these blood problems are rare. And so there's not people out there in private practice, they might deal with iron deficiency anemia, but they don't deal with leukemia. It has to be in a hospital base. There are community-based programs that might only treat, basic leukemia and send everything else out. And then there's large academic centers that treat everything under the sun and get the referrals for all the other cases and all that kind of thing. Some people are generalists, meaning they do all the things I showed you on my previous slide. If you can believe that, some people do everything there. Whereas at other centers, mainly large academic centers, people super specialized. So in my center, we're pretty specialized. So I do oncology only. And within oncology, I do neuroblastoma and I don't do other stuff. And that's it. That's all I do. So at another place, you do everything, but you can choose sort of where you want to do that. You go into something more specialized. Most people are involved in some type of research. It might be basic science, meaning they work in a lab. It might be clinical research, meaning they work on clinical trials like I do, or it might be translational research, trying out new drugs. Most people have a mix of clinical and research time. I'm about 50-50. Most people have some of both. There are some people who only practice clinical medicine, and there are some people who only run a lab and don't do anything clinical. But for most people, there's a mix. Some people, after they complete a peds hem-onc fellowship, they go work in industry, meaning a pharmaceutical company. So pharmaceutical companies need peds hem-onc doctors to test drugs, run clinical trials, do laboratory experiments, all that good stuff. So many people do leave academic medicine and go and work for pharmaceutical companies after completing their fellowship. There are some newer sort of career options. People are now doing things that are more like shift work, and people work as hospitalists, doing only inpatient peds hemonc, which is kind of a new thing. And you don't do research, obviously, you're really just an inpatient clinical person, but it is a sort of new way that the career looks like. But most people who work in academic centers, you know, have this sort of mix of clinical and research work, and spend their time that way. Okay, this is the question that always everybody asks me. Is it really depressing?
Yep.
It's like the biggest downer thing. Like when I'm out with people and it's like, oh, what do you do? And I'm like, oh, I'm a pediatric oncologist. And then they make this face. They just go, oh, and like then they like walk away and they like make an excuse and go talk to someone else. So yes, there are really tough moments. And when kids die, it's really sad and everybody cries and it's awful, right? But the good far outweighs the bad. In pediatric oncology, overall, there's 80% survival. It's very, most of our patients do well. I would never want to be an adult oncologist, right? Everybody dies in adult oncology. That's really depressing. To me, that's really depressing. Kids do great. They're going to school. They're doing all these awesome things. So this is one of my favorite patients who's doing great now, by the way, but this was in the middle of treatment and he's just rocking it. He doesn't care, right? They just like sail through it. It's amazing. You need a lot of support to work in this career. You need the support of your family. You need the support of your colleagues. Everybody, we do a lot of touchy-feely stuff. We meet together after people die and we hug and we cry and we talk and, people, not everybody's into that. Okay. My husband is a spine surgeon and he's like, oh my God, what is going on? This is not something orthopedists do. Like they're not hugging each other and like talking about their feelings. Give me something to
bang on.
Right. So, but you need all this support, right? And you need a certain amount of resilience to be okay in this field. You have to be able to figure out how can I handle it? When a child dies or a patient relapses or things go wrong, how can I handle that and still keep going, right? So you have to have a certain amount of resilience.
Yeah. Talk about for a second, because a lot of people listening may hear you go, we cry.
Yeah.
And they go, well, doctors aren't supposed to cry.
Oh yeah. We
that's
cry.
Unprofessional.
Yep. And that's such a good point because, there's the right moments, right? And I'll talk about this. I had a really tough conversation with a patient today that I've had for many, many years, who has having another relapse and who's sort of at the end of the line. And I had to have the talk with the parents today that there's no more treatment and we're not going to cure him and we need to start thinking about other things, right? And I got choked up and I cried with them a little bit, but it wouldn't have been appropriate if I became hysterical and couldn't have the conversation. So there's the moments when it's okay for me to cry. And I think the parents maybe feel better when they see that I'm emotional about their child too. That's how much I care for them. But for my own self to be really let go and really have a good cry, then there's the moments for me to do that with my colleagues or with my family or with other people. But it's absolutely a really important part of working in a field like this, that you can process those emotions. And one time when I was new into being an attending, maybe 2 years in, and a baby died while I was on service and it was really rough for me. And I was crying quite a bit, not with the family, but separately. And one of my mentors, I said something like, oh, I wish I could just stop doing this or get a hold of myself or something. And he said, Julie, if a child dying doesn't make you cry, you shouldn't be doing this anymore. You're done. And that was really powerful to me that okay, I'm having this response because this is a normal emotional response to a baby dying and that's okay. So I think it's a very important point that you bring up because like my husband in his field where it's really not okay. In our field, it really is something that is accepted. And we all recognize that we have to deal with what we're going through or else we're not going to be able to keep doing this, right? Yeah. We can't do it.
Great. Thank you for that.
Yeah. All right. So work-life balance, because this is something I think a lot of people care about more. Yes, these are all my children, all of them. The youngest one is 5 months old and the oldest one is about to be 7. And so I think I can speak pretty well to what work-life balance is like. And I will say that it's challenging. Having a family and having a busy academic career is hard. But it's so rewarding and it's so doable. So in our field, you have more control over non-clinical time, right? So when I'm on my clinical time, when I'm an inpatient attending, I have no control over my time. I'm in the hospital all day. I'm answering the phone at night. I'm on call. I have no control. But the weeks when I'm predominantly doing non-clinical work, when I'm doing research, I can schedule my time however I want, right? So I can come home early and be with my kids. And when they go to bed, I can get back on the computer and do work. So you have good control over non-clinical time. And I like that. That's one of the things that gives me good work-life balance. The ability to do more remote work in the past 2 years has also been really helpful for letting me do my 7 a.m. meetings at home instead of, being in the office at 7 a.m. And yes, there's a lot of children screaming during that time, but like I'm still on a meeting that I otherwise would have had to be in the hospital for. So that's also been helpful. And being flexible with my time. Like I said before, a lot of days, my kids go to sleep early because they're really little. So I leave my office at a good time so I can be home and have a couple hours with them. And then they go to bed. And like now I have peace and quiet and I can do work again. So you have to have some flexibility with your work. But in this career, it is very, very possible to have work-life balance. It is doable. You can have it. The other thing I will say is that we have an au pair that lives with my family. She is literally runs our lives. She's like on top of the kids' homework and packs their lunches every day. I am not the person who does that. And you have to be okay with that. I'm okay with that I don't know what's happening with homework and I have no idea what they ate in their lunch today. I'm there for other things. And so to me, having someone that I can count on at home who I know is taking care of everything is what lets me do my work. So you have to have help that you can really rely on. And that's a really, really important part of having good work-life balance.
I remember very early on at New York Med, I don't know if you were there for this talk, but I'm pretty sure it was a female neurosurgeon. It was a panel of women physicians, I'm pretty sure. And one of the things that they brought up, and it just stuck with me, and it still just resonates, is she talked about having kids during residency, during fellowship, whatever. And she's like, babies don't need you.
Right.
They need food.
Right.
They need a breast, however that comes.
Yeah.
They don't have questions about life and dating and all that stuff. Like they need you later on. So be okay having an au pair, having a nanny, being at work earlier on. And as your life changes, you can adjust to be there more when they need it.
And Ryan, I wish I had listened to that talk because it took me a few years to get there. When my oldest two, we didn't get an au pair till my this one who's almost 5 till she was 2. And I was trying to manage everything and I was making myself miserable because I just didn't want anybody to help me. And it was only once we started having au pairs and I was like, I don't actually care about this stuff. And having the freedom to be with my kids and just be with them and not stress about that stuff. And then know that if they're sick or there's a snow day, I don't have to stress about childcare, like it was mind blowing. It was so life changing to accept that help. But I think probably many people are like me and it's a little hard for us to get there. We want to do everything ourselves. And I had to go through my own learning process to sort of realize that like, I don't have to do everything myself. And only when I got more help, then I was like, now I'm really, having a much more success in my career, I'm happier at home because I have help. So you should tell everyone that because I definitely wasn't listening to that talk.
Okay, will do.
Okay, so what does my day look like? So I'm being totally honest with you guys. This is like what I did today. So I wake up between 5:30 and 6:30. Talia is my alarm. That's my littlest baby. So I feed her. That's all she needs from me is her milk. And I get dressed and I drink some coffee. I get my toddler, my 2-year-old dressed and I feed her breakfast. I pack up all my stuff. My au pair starts at 7:30. And that's when I leave the house. I drop one of my kids off and I get to my office around 8. I pump first thing when I get to work, do that magic milk making. Then while I'm pumping, I multitask. I answer emails. I eat breakfast. I follow up on everything urgent from the night before. Then I start seeing patients. I see patients for checkups. I see patients to clear them for chemo. I see new patients for consults. I pump while I eat lunch, do a little more email. In the afternoon, I usually have a lot of meetings. I have to write notes from the morning. I have to write more chemo. I have to pump again. I do some teaching. I meet with the fellows. I do some clinical trial work. And most days, my goal is to leave my office by 5. I have family time for a few hours while my kids are awake. And then I would say generally most nights I have half an hour to an hour of sort of catch up tasks, the urgent things that I didn't get to, finish up my notes during the evening time. So I usually do work at night a little bit. And that's personally me because I hate leaving things undone. If I didn't sign my notes off from the day, if I know there's something for tomorrow, maybe I could leave it until the morning, but I hate that and it bothers me. And so I get back on my computer and I finish up my work. And then I try to have a few minutes, like my husband, I like to sit around and, actually talk to each other for a few minutes in the evening time. Things that are not in this time frame are showering, which I'm totally honest, it doesn't happen every single day, no matter how hard I try. Exercise, I really try. It does not happen on most weekdays. Weekends, I can get it in. Weekdays, it's hit or miss. But this is my day and it's really jam-packed from the moment I wake up until the moment I go to sleep. But it's all a lot of fun. And there's, I have a schedule that works for me. So all this sort of coalesces to make my day work.
Awesome.
Okay. So now I have a couple of cases. Should we do the cases? Should I answer people's questions? What's like the thing that we should do now?
Let me look at some Q&A here. Q&A only. What does your weekend schedule look like?
Okay.
Hopefully pretty free.
Well, that's a good question. So everyone in my division, we split up weekends. So when you're on call for the weekend, it sucks because it's the only time, like during the week, we split up oncology, hematology, and transplant, 3 separate attending. So I only do oncology. On the weekend, we have 1 attending covering all the patients because none of us want to work many weekends. So on the weekends, it really stinks. You're in the hospital, pretty much all day Saturday, all day Sunday, but I only work 4 weekends a year. So it's really not a lot, and it's very manageable to say, okay, I'm only going to work 4. It's going to stink, but 4 weekends a year, I can handle it.
Yep.
Yeah.
You talked about doing research. How much of your job is doing research?
Yeah. So the research that I do is clinical trial work, and I work on early phase oncology trials, which means phase 1 and phase 2. The phases when drugs are being tried for the first time in pediatric populations.
Yep.
Most of the time they've been tried in adults, but it's the first time they're being tried in kids. And so that's the research that I work on, and it's awesome. I work with, the IRB and the FDA, and I enroll patients on studies and do consenting and, monitor their treatment and report back to drug companies. I work a lot with drug companies who sponsor the studies. And so that's really awesome research. I'm not a bench person research, God bless those people. That's where all the discoveries in cancer have happened, right? In labs, people discovering awesome things. So that's a really important part of our field. Someone has to do that. It's totally not me.
Yeah. And you are not a PhD, correct?
I'm not a PhD. And a good number of people in our field are, because there's that hardcore basic science element to cancer and to cancer treatment. And those people with MD PhDs, they often do tend to do that basic science research, and they run labs. And they might also do clinical work, but many of them run labs and work on drug development or looking at, markers of aggressive disease or other really cool things like that. So that stuff is awesome. And a lot of the best and smartest people in our field have PhDs, and they really focus on that basic science part.
Yeah. A good question here from Amy. And then I'm going to ask a follow-up question after this.
Okay.
So any lags in pediatric cancer research funding versus adult cancer research funding?
Yes, Amy, great question. Heartbreaking answer is it's pretty horrific. The numbers are staggering, the amount of money that's devoted to adult oncology research versus pediatric oncology research. The same thing goes with clinical trials and drug developments. For every, 20 adult clinical trials, there might be 1 pediatric clinical trial. There was a lot of mandates in a lot of the new funding for clinical trials that they have to offer some version of pediatric trials in order to get funding for new trials. So the government has tried a lot of incentives like this. There was the moonshot incentive, which was going to put billions of dollars towards pediatric cancer research. COVID happened, a lot of things happened. But the short answer is that the funding is really, really lacking compared to adult oncology. And that's a lot based on numbers, right? Like in the US, there's 200,000 or so, a couple 100,000 new pediatric cancer cases every year of all types of cancer. There's over 200,000 cases of just breast cancer. So the adult numbers just dwarf the pediatric numbers. And so they just don't, it's a numbers game, right? Why should a drug company develop a drug for 100 new neuroblastoma patients per year when they can develop one for colon cancer, of which there's 4 million, Yeah. So I get that. I really do, but we need those treatment options and those research, and we need that funding.
Okay.
Yeah.
So follow up to the funding question. Just this week, so it's interesting timing to have you on. Just this past week, Tufts Children's Hospital announced that they are closing and converting those beds to adult beds.
Yep.
Probably along the same lines that pediatric reimbursements are just much lower than adult reimbursements. Do you think that's going to be like a domino effect in the world of children's hospitals? If there's 2 children's hospitals in one city, like there's only going to be 1 in the future?
Which is a scary thought because, all of them are needed. And I wasn't sure if I should talk about this because I really don't want to discourage anybody from my field because obviously I love it, but the pay is not great. Yeah. I think most probably people do know that, the same specialty of peds and adults, the peds specialties make significantly less for every single specialty. And that has to do a lot with reimbursements. Peds things are just reimbursed much less, which is ridiculous. but it's the way it is. So pediatric oncologists make significantly less than adult oncologists. And I'll tell you, I spend hours with patients, and adult oncologist comes in and is like, hey, okay, how are you? Bye. Like, I don't get it. It's baffling to me, but it is the way it is. So the pay in our field is not great. The pay in most pediatric subspecialties is not great. And the reimbursement for hospitals in all things pediatric is not great. There's very few things that make money for the hospital in children's hospitals because of the way reimbursements are. So I don't think it's going to happen to every hospital because, there are kids who need beds, but I do think in places like Boston, where there's probably a lot of children's hospital beds, they're not going to be able to support so many. And part of the problem is Boston Children's Hospital is such a big hospital with such a name and such a presence in all the specialties that it's a little bit hard there. So I hope the situation won't be quite the same, for all pediatric areas, but it is, it's worrisome, and it's something that, in the many problems of our healthcare system and the payment system and the insurance system, the fact that pediatrics are valued so little is a real problem.
Yeah, it's scary. Quite a shock. I had our friend Mo, who we went to med school with. She did her pediatric residency at Tufts Children's, and so I texted her. She said the attendings were just like, they were interviewing people to come work there. Yeah. One day, and then the next day they're like, yeah, never mind.
Yeah, they had matched residents and fellows for the summer. It's awful. It was clearly it was clearly a shocking decision to everybody. Yeah. So,
all right, let's move on to some more fun, I guess we call it.
Yeah, let's do some cases.
Do we want to bring students on so we can ask them questions?
Sure.
Or you want to just run
oh my God, I love that. No, let's do it.
All right, I'm going to clear everyone out. If you want to come on and ask a question, raise your hand. Why don't you go ahead and get started, because it'll take a couple seconds.
This is a case that this is a patient I have right now. She just presented. So she's a 3-year-old. She is totally healthy. She has had about a month of constipation, some abdominal pain. She's gone to the ER. She's gone to her pediatrician. Every time she's seen somebody, they gave her laxative. They gave her enema. She had big poop. She felt better. They did basic blood work. It was all fine. They did an abdominal x-ray. It was fine. So this is one of the cases, I'll tell you, I don't envy general pediatricians. It's really hard to be a general pediatrician, right? How do you know when you should do more workup? When is it not normal, right? That's really hard. And, I have the benefit of being the person, like, I don't even hear about this kid until they've already had their workup and I get called about it. So I get to be the Monday morning quarterback because I wasn't involved there. But the question is, how do you know when you should do more workup? And for this kid, it was the fact that the constipation, the abdominal pain was getting worse and worse, and it just kept going on, and her belly was becoming quite distended. So what should we do next? Let's ask that question.
So we'll ask in the chat. Nobody's raising their hand. They're all scared. So
okay. We'll anybody want to shout out a guess? What should we do next?
So Alicia there, when the problem is persisting with symptomatic treatment.
Yep, agree. I totally agree with you, Alicia. What does anybody think? She's had blood work. It was fine. She had an abdominal x-ray. It was fine. What should we do? Anybody?
When do we do it? CT scan. CT. No.
Okay.
What do you do?
Yeah, so I like all these people mentioning imaging, and imaging is a great thought. However, in kids, there's a few things that you have to consider that we don't consider in adults. 2 factors. One is CAT scans cause radiation. So we try to avoid CAT scans whenever possible in children because there is radiation, and many of them might get a lot of them. Now, the second thing is we could say, well, let's get an MRI because there's no radiation from MRI. But guess what? MRIs are really loud. They make this boom, boom, boom noise, and you have to hold perfectly still. So guess what? No 3-year-old on the planet can do is lie still for an MRI. So we have to sedate children for MRI. So that's a big deal also. We don't necessarily want to sedate her right off the bat. So what's the first thing we can do that requires no sedation and no radiation? Does anybody know? Anybody can tell me a type of imaging we can do that? Yes, somebody said it. Ultrasound. Very good. So good. Ashley Scott for the win there. So ultrasound is a type of imaging that we can do where there's no radiation involved and this patient doesn't require sedation. So the patient got an ultrasound, which showed something pretty crazy. So then we did have to sedate her for an MRI, and this is her MRI. So this is, I don't know if, can you guys see my mouse? This is a...
No.
Oh, okay, fine.
But you can draw on the screen. There's a little turn whiteboard on.
I see that. Oh, yeah, look at that. Okay.
Over it.
So that's a tumor. I probably don't need to draw that for you guys, but that's a tumor that shouldn't be there, right? So there's bowel underneath. You can see that. Hold on, I'll turn this back on. The liver is here, right? So her liver is there and her liver looks fine. And these are all her intestines. And you see they're all filled with gas and poop and all that kind of stuff. But smack in the middle of her belly, she has this big, giant tumor. So that's not good. Obviously, that's when I got called. Oh, wait, let me turn this off. There we go. So what are big giant tumors in the belly? There's a few different ones: Wilms tumor, neuroblastoma, germ cell tumors, lymphomas. Now, we can get clues from imaging, but there's only very specific circumstances where we can make the diagnosis from imaging. One of them is a Wilms tumor, because that's a tumor of the kidney, and it looks a certain way, and the tumor is actually like inside the kidney, and we can say that's a Wilms tumor. No other tumor can we really do that with. We have to have tissue. We have to look at the tissue under the microscope and see what is it. So we did a biopsy.
So there's a good question from Mary.
Yes.
Apparently Mary has read that histories and physical exams are important. Is this palpable on exam?
So her belly was, it was very firm. She looked a little bit pregnant for a 3-year-old, and her whole belly was firm. And what you were feeling was the mass. You couldn't really feel the edges of it, but for sure you could feel that it was firm in a way that a belly should not be. And Mary, that's a great point. We didn't even talk about her exam, but when I first met her, I said, oh yeah, that kid's got a giant tumor in her belly. It was obvious. It was definitely obvious.
Mary's an ER scribe, so she knows.
I like it. I like it, Mary. All right. So this girl had a needle biopsy, and this is what it showed. Does anybody know there's a special name for this group of tumors? And there's a clue based off of how it looks right here. This is like med student level knowledge. This is not like pre-med student level knowledge, but this is called a small round blue cell tumor. And the cells are small and round and blue. And there's a whole group of small round blue cell tumors and that look like this under the microscope. And they're neuroblastoma, medulloblastoma, rhabdomyosarcoma, Wilms tumor, and Ewing sarcoma. So there's a whole group of these that are small round blue cell. Now there's other tests that the pathologists do on the tissue in order to figure out which one it is. You can't tell just by looking about everything what it is, okay? But I've already told you guys that I'm a neuroblastoma specialist, so you can probably have deduced already that this patient had neuroblastoma. So this is the neuroblastoma risk group stratification. This looks like a hot mess, but it's actually super awesome. It's a chart that allows you to look at the stage of the tumor, the patient's age, some things about their histology, and to figure out the whole goal here is, oh my gosh, I don't know how to get rid of those ones, but I'm
ready. Does it? Oh, it just doesn't. Wait, there's a clear button. Hold on.
Let me see. Do I see it over here? Oh, I can like erase it manually, but that's annoying.
Yeah, no, that's annoying.
Forget it. Okay, I'm not gonna do that. Okay, well, this part over here, the far right side that says risk group, right? That's really important. That tells us. Oh, thank you.
Our heads, our giant heads were blocking the.
Yeah, I got it. That was a problem of that. So, oh, I'm on the erase one. I'm like, well, I want to draw now. So this group over here, this guy. Oh, I want it now. It won't let me draw. I don't know what I did wrong.
There. Try again.
No. Oh no. All right, forget it. This is like technology is not my friend. So the category over here that says pre-treatment risk group, this is really important. This helps us figure out what to do for the patient. So this patient, I'm just going to tell you guys a few things about her. She was NMIC non-amplified, and I want to take 1 second for a tangent here, which is that over the past 10 years, molecular genetics have really changed so much about oncology. So now we can do molecular testing on tumors, and we can actually look for genetic variations and mutations within the tumor. And we've learned a lot that way. What mutations make something a bad actor? What mutations make something easier to treat? What mutations are there targeted drugs for? So NMIC is a specific alteration in some neuroblastomas. And when it's amplified, it's very bad. When it's non-amplified, it's good. So this patient was NMIC non-amplified. She had what's called an L2 tumor, meaning she had no metastatic disease. Her scans were negative. Her bone marrows were negative. So now I'm going to show you guys where she falls out. So this patient had an L2 tumor. She's over 18 months of age, and that's really important. Her tumor was poorly differentiated. Her NMIC, this category right here, NMIC was non-amplified. And so her final risk group is intermediate risk. And that's great for her. Intermediate risk neuroblastoma is a good thing. So this is survival. And low risk and intermediate risk patients do awesome. High risk patients, not so much. And I'll talk about that a little bit more. But high risk neuroblastoma is bad news bears, and really, really difficult to treat. So the low risk patients and the intermediate risk patients have very good outcomes. So this was a very happy outcome for this patient. Now, what did we decide to do for her? Some of these tumors, intermediate risk neuroblastoma, you can just remove it with surgery. However, in her case, the tumor was so huge and it was wrapped around all the blood vessels. And the surgeon said to me, like, no way are we taking this out safely. Let's do chemo first. So she got a Metaport put in, which is a little device under your skin for giving chemotherapy. And she is getting 2 cycles of chemotherapy. She's about to start the second cycle now. The cycles are about 3 weeks each. You wait for the blood counts to recover between each cycle. After her second cycle, I'm going to get her another MRI. We're going to see how much her tumor has shrunk. If her tumor has shrunk enough that we can remove it, great. She's going to be done with treatment. If it hasn't shrunk enough, I'll probably give her a couple more cycles of chemo and try to get it a little bit smaller. But she has an excellent prognosis, okay? Her cure, she's going to be cured. And the goal for her, I really want to limit the toxicity of treatment. All these chemo drugs are toxic. They all do nasty things to you. So the goal for her is to give her the least amount of treatment possible while getting this thing out. So I'm hoping to give her 2 cycles and get it out, and that would be a great outcome for her.
How close are we to targeted therapy in the pediatric population?
So we're doing it. We're doing it. And that's awesome. And for many patients, there's a couple of diagnoses. So for example, I have a couple patients who have tumors that have an ALK mutation. And that's a mutation actually that was first identified in lung cancer in adults. And because it was identified in an adult cancer, it has a treatment drug for it. If it had been found first in a children's cancer, I'm sure it wouldn't exist, but it was found first in lung cancer. And so people said, hey, wouldn't it be great to make a drug that targets this? And that has actually changed lung cancer therapy. But for patients who have these tumors, instead of getting chemo, all they do is take an oral medication by mouth now. And that's it. It gets rid of their tumor. So targeted treatment is for sure, changing the way that so much of what we do. It's not going to replace traditional chemo ever, because there's some things that just really need it, but it's definitely changed so much of our practice. So much of our practice. Someone asked a really good question that I just want to answer, which is, why would laxatives made her feel better? And that's such a good question. So she was super constipated because this giant tumor was like squishing her intestines and she couldn't poop. So every time she had laxative, she was able to pass a very large stool, and she was like, oh, now the pressure was off of her belly, and she felt so much better. But then her poop would build up again, the pressure would build up again, and she would feel terrible again. But because she was able to have these giant poops, it would relieve some of that pressure in her belly, and she was feeling better. So common things are common, right? And so a kid comes to you in your office and you're a general pediatrician and they have belly pain and they haven't pooped in a week. You say, okay, give them some Miralax and all is going to be well. And 99 times out of 100, actually like 99.9 times out of 100, you're going to be right. It's not a tumor, but 1 time out of 1,000 times, it might be a tumor. And so, it often takes children with cancer several practitioners and several visits to be diagnosed. And that's very normal because, you don't get an MRI and every kid who comes in and says, ow, my tummy hurts. I'm sure, Ryan, your kids say my tummy hurts all the time. And it's just like something kids say. So it's very hard for general pediatricians. They have to be really experienced in trying to figure out what are the concerning things to look for and what's not. Anybody else have a question about this case before I do have one more case to talk to you guys about? I'm just looking to see laxatives.
Yeah, let's rock and roll.
Okay. All right. So the next case is a 19-month-old. She came to the ER because she'd had something really rapidly progressing, which is she had swelling over her left eye. And it had been getting huge, like very, very fast. And she'd had fever for a couple of days. So she had a CT scan that showed a mass behind her eye. Now she got a CT scan because something was very enormous on her eyeball, and it would have taken a while. You have to wait and make a kid NPO. You have to let them not eat before they can get sedation. Sometimes it takes a day or two to get a sedated scan. So she got a CT because they needed to look immediately. So then she got more CTs. She got MRIs, she got MIBGs, and it turns out she has neuroblastoma everywhere. Now, an important thing to mention, so I mentioned in here that she had a bone marrow biopsy, and I mentioned it for the other patient as well. Why do we do bone marrow biopsies on a solid tumor? Great question. The reason is because neuroblastoma actually metastasizes to the bone marrow a lot of times. So in this patient, they had metastatic disease to the bone marrow. Now, as opposed to the other girl, right, she was doing pretty good. She had this one giant tumor. This this baby does not sound okay, right? This is another real case of ours. She has tumor everywhere. She has disease in her bone. She has metastatic disease in her bone marrow. So this is not the same situation. This is a bad situation. This is called high-risk neuroblastoma. Okay, now let's look at her on the chart. So she has M, which stands for metastatic disease, over 18 months. That's a bad prognostic sign. For her, a metastatic disease over 18 months, nothing else matters. The NMIC doesn't matter. The genetics don't matter. If you have metastatic disease and you're over 18 months, you're automatically considered high risk. And unfortunately, the high risk patients, as I showed you on that other graph, they have very poor outcomes. So what do we do for high risk patients? Yeah, this is a graph for high risk patients so this is looking at, this is very interesting actually. So during 1970, 1985, patients, it was universally fatal. Really, patients with neuroblastoma did not survive with high-risk neuroblastoma. Between 1986 and 1995, they increased the intensity of treatment 4 times over. They give so much stronger chemo. I mean, like just crazy intense chemo. And they only got a little bit more survival, which is pretty depressing. And now we've improved from there, but we really made things sort of like as intense as we possibly could. And so the gains that we've made since 1995 have all been with targeted therapy, with immunotherapy, and with other types of treatment, because you really can't give any more chemo than we're already giving. So what do you treat high-risk neuroblastoma with? 6 cycles of induction chemo, and each cycle is like super intense and strong and wallops these kids on their back. You do surgery after the 5th cycle if there's a big tumor to remove. Then you do tandem autologous transplant. Now, autologous transplant means using your own body stem cells. Why on earth would we do that? Now, the reason that we do that is because chemotherapy suppresses your bone marrow. It causes your bone marrow to stop producing the important blood cells. So your red blood cells, your white blood cells, and your platelets, your bone marrow stops producing them because of the chemotherapy. But we only give a dose of chemotherapy where it stops producing it temporarily. And then the bone marrow will start to produce it again. So the counts go down for a little bit and then they come back up after the cycle. The goal of autologous is to give such a crazy high dose of chemotherapy that we kill your bone marrow permanently, and then we give you your own stem cells back so that your bone marrow will regenerate and start making red blood cells, white blood cells, and platelets again. So that's the whole purpose of autologous transplant, of using your own blood cells, is really to give you such intense toxic chemo that your bone marrow would be killed permanently. That sounds awful, but it's true. And tandem means we do it 2 times back to back. So you do it, the kid has a break for a couple of weeks, and you do it again. After that, they get radiation, and after that, they get immunotherapy. So this is basically like 18 months of totally crazy, awful treatment that just, is insane. Now, that being said, the survival has increased to about 60% now. About 2/3 of patients with high-risk neuroblastoma can now be cured because of all this intense treatment, but it's super, super intense. It's very, very crazy treatment.
Have we, what have we seen in terms of parents who refuse treatment? I know there was a big case in Connecticut, I believe, where the state took custody of the kid and gave therapy, but that was a leukemia, I believe.
Right. So it very much depends on the expected outcome. And this is one of the things that I struggle with, like as adult doctors. I don't know how they manage this. Like if an adult wants to just like let themselves die, they can just do it. You can just leave the hospital. You can say no to chemo. You can say no to antibiotics. Adults can do whatever they want. That's not the case with kids. We pretty much have free reign to do whatever we want. Now, the ability of parents to refuse treatment completely has to do with the survival. If we can say that with this treatment, there's a good chance, more than a 50% chance your child is going to live, there is really no court who will allow you not to treat the child. Leukemia is like a slam dunk. The survival rates for most leukemia are 80, 90%, right? So no one's going to do that. On the other hand, there are some brain tumors or some things where the prognosis is very dismal. And I'm saying to the parents, I cannot cure your child no matter what we do, but there's treatment that might prolong their life. It's completely within reason to refuse that treatment. If they don't want to do that treatment, that's totally okay. So it very much depends on what the expected outcome is. But we have had families that we've had to take to court over leukemia treatment or something like that. And it's an awful experience for everyone on the team. It's a really terrible experience because we're literally fighting to, treat a child, and the family may have some, misguided opinions about chemo, or, the one time they wanted to use
I read a post on Facebook.
Yeah, exactly. They wanted to use rock crystals and, things like that. And it's just like, this is a horrible situation already, but it makes it so much worse to have to deal with that. That's really hard. That's really, really hard. And then I just want to finish with one thing, which is this is from 1975. And this was a very profound guy who wrote that as the number of survivors increases and the length of their survival also increases, concern is being expressed because of the late consequence of successful treatment. Every treatment has an undesirable side effect, some minor and some major. Cure is not enough. And that has really turned out to be true. We cure so many children now, but unfortunately, over 60% of survivors have chronic illnesses. And over, about a third of them have severe or life-threatening chronic illnesses. And that's because of the treatment that they get. So all these children that we're curing of their disease, they grow up to be survivors who have lifelong medical problems. And so really our goal now is how do we figure out how to reduce the toxicity of treatment? So there's so much left that we want to do. We need to maintain the high survival rates while reducing toxicity. We're still looking for breakthroughs for non-curable diseases like certain brain tumors. We work on targeted therapy, molecular genetics, and we need to work on improving the quality of life for patients and families. So these are all areas where there's tons of active research. There's so much progress still to be made. Is that that's my last slide, except to say why I love it. But, there's so much that we can do because there's a lot left to improve on in our care.
That's awesome.
Yeah.
Thank you for all that.
Yeah.
I have a couple students here.
Yes.
Emily, unmute yourself. Ask away. Maybe.
I can't hear
Alicia, unmute yourself if you can.
Can you hear me now?
Yes.
There we go.
Okay, yeah. My question is and I believe this might sound like really stupid, but I was talking about this and it came up in neuroanatomy this week. Or last week it was about tumors, but is there a difference between undifferentiated and not well encapsulated?
So those are totally different things. Yes.
Okay.
So differentiated has to do with how do the cells look under the microscope, right? Are they differentiated means more looking towards the normal grown-up healthy cells that they should be, versus undifferentiated means they're still very primitive cells. They haven't sort of branched off to that adult type of cell. Encapsulated is an anatomical thing. Is the tumor sort of nicely wrapped up in plastic wrap, or is it branched out and grabbing onto all the different parts of your anatomy? So those refer to different things, and both of them are really important for a cancer, right? Encapsulated is good, easier to get it out, and differentiated is usually better because it means they're more mature cancer cells versus very undifferentiated primitive cancer cells. Very good question.
All right.
Thanks, Emily. Alicia.
Can you hear me now? Okay, great. Thank you, Dr. Krystal and Dr. Gray, for this amazing session. I just have a question about the training. So when and how do student doctors get to the training about how to address parents or family during a loss? And is there a specific protocol to which you're trained to follow to help them grieve through it?
Yeah, that's a great question. So it's something that is not part of really medical school, and it's not really part of general pediatrics residency. It's really something that occurs during fellowship, because you really do need to have all the experience and all the knowledge to bring with you to have those kind of conversations. So in fellowship, we start to work with our fellows to be able to have those conversations. And they do training. They do a lot of training where they do simulations with fake patients to say, you're going to talk about bad news, all that kind of stuff. And then they also get, training in real life with families where they have to really go through those conversations. And it's a very good skill, right? So I was telling Ryan before we started this that I had a very tough conversation today with a patient I've known for a very long time and had to speak to them about, I think I told you guys this, the end of, sort of treatment. And there are certain phrases and certain wordings that I always use. There are certain tactics I always rely on. I say the same things in many of those talks. I use the exact same language because I've sort of developed my tool set for having those discussions. So it is something specific to our field. Most fields of medicine don't need to do that and don't do it very often, but I do it a lot. So I have to be really good at it. But it's not something that really comes into training until fellowship.
Yeah. Thanks, Alicia.
Thank you.
Hello, Michelle. You can unmute yourself, please.
Hi.
Hi, Michelle.
I had two questions. So the first one was in relation to the discussion about having to fight parents in terms of court. So I was.
Oh, I think I lost her.
That stings. I'm gonna turn her video off and see if maybe that helps.
Okay.
All right, Nadine, say hello. Unmute yourself there.
Can you hear me?
Yes.
Okay, great. Well, thank you for doing this. I really enjoyed it. And so my question is based on what you said, and I think that's what Michelle was gonna ask about court as well. Oh, she's gone. Oh yeah. As well, because my biggest concern is what about parents who they're not. I want to start by saying I'm currently like doing research or PhD with cancer as well, and sometimes when like Uber drivers or other people like ask me what I'm studying and I say cancer, then you listen, you realize they don't know as much. They just know that it's bad.
Yeah.
And so is there a way that you get to have like classes or sessions with parents who don't want the treatment, not because they're evil for their kids, but just because they don't understand it?
Right. So that's a really great point. And it's our job. It's something we have to do in pediatrics that adult doctors don't have to do. We have to make sure that the parents understand everything. So there's something in pediatric oncology called the day one talk. And that's literally where you sit with a family and you say, this is the diagnosis, right? Your child has leukemia. And then I sit there and explain, what is leukemia? How did leukemia happen? Why did this happen to your child? It didn't happen because of playing video games or not eating organic foods or a lot of misconceptions that people have. You know, there's nothing you could have done to prevent this. There's a lot of I say all those things. So I explain what leukemia is and how did it happen. And then we go through what treatment is needed. What is chemotherapy? Why does chemotherapy work? Why do we have to use chemotherapy and we cannot use crystals or vitamins or essential oils or any of the other things that you want to use? You know, this is how it has to be. So that's an established part of every parent, no matter what their education level. You know, parents who are doctors and lawyers and whatever, they still get that talk because every parent needs to understand all this information. So we call that the day one talk. It's on the first day. And that's a very important part of sort of starting off therapy, is making sure that the family understands everything. Now, even after hearing all of that, some parents will say, I don't believe you. I don't think that's true. What you're saying is not true. I read in my Facebook group that if my child just cuts out sugar, they don't need chemo, right? Like I've heard it all. So that's what happens, that a lot of families still don't believe the information.
And do you like get to like progress, especially after like a first case of like chemo? Because I've read that this is a true story. Like a kid, he got like a first stage of chemotherapy and then his classmates start bullying him because he lost his hair. They thought it was contagious. So do you get like cases where when they have the chemotherapy, they start thinking you're doing worse than better? Like,
yes.
Do you get to like move on from that by teaching them more?
Right. So part of it is about in that day one talk, making sure they understand, right? I explain in detail why the hair falls out and that's actually a sign that the chemo is working and stopping your cell cycle, right? So all that information has to be given to them in the beginning. This is why, nausea happens. This is why the blood counts go down. These are all actual, even though these are side effects, right? And maybe the child doesn't feel good for a few days here and there. This is how the chemo works. And this is why it's important. So all of that education can help to avoid those problems if you explain that in the beginning so that they understand why all those things are happening. So parent education is a huge part of what we do. I mean, hours and hours of every day of my job is sitting and talking with parents. And that is so much of what I do because they have to have all this information. They have to understand what's going on. They have to be on your team together. Everyone has to be on the team together in order to really have success and avoid those kind of conflicts that you're talking about.
Thanks, Nadine.
Okay, thank you so much. That really helped. Thank you.
You're welcome.
Last but not least, Pradeep.
Hi, thank you. I just want to say thank you so much for being here. You've really inspired us, and we're learning so much from you guys. Thank you so much. So my question is, about cancer. Do you think that in terms of technology such as CRISPR and other things could be like humanity's final leap against our battle against cancer?
So CRISPR is awesome. Now, the problem is CRISPR is not going to cure cancer because CRISPR, think of it like scissors, right? CRISPR is great at cutting and cutting out something specific. Most cancers are not caused by just one gene problem that you can just cut it out and get rid of it. So there's ways in which I'm sure CRISPR is going to be awesome. CRISPR is not going to be the final solution to cancer. However, CRISPR has already changed a lot for certain things. Like I mentioned sickle cell disease. Sickle cell disease is single gene mutation. One mutation makes one amino acid incorrect, and it causes this huge devastating chronic illness that kills tons of people prematurely, right? So scientists have been able to use CRISPR to figure out strategies to do gene therapy to cut out that mistake and fix it and correct it for people. So CRISPR is going to revolutionize and change management for a lot of genetic-based illnesses and other things like that, but not necessarily for pediatric cancer.
Oh, okay. Okay, awesome. Thank you so much. I really
You're
appreciate
welcome.
it.
Great question. Thank you.
There's a lot of other questions I see in the chat, but I know.
Hey, there's always so many. I have one final question. What is your husband's drink of choice? Because he was back there
making a drink. I know. John,
sure.
what drink did you make? An old fashioned with mezcal.
There you go.
My husband works hard also.
It was a science. He's like, oh,
I know. I'm like impressed you noticed that. I didn't even see him doing that. I was too involved in our discussion.
So when is he coming on eShadowing to talk about spine surgery? Because that'll be
John, you want to talk about spine surgery?
Not tonight.
Med students? Not tonight. He would do it. You know, it's funny because like we're so different, right? In our work, like my work is all about touchy feely and all these talks. And he's like, I saw 30 patients today. I talked to each one of them for 30 seconds. I'm like, what?
Can you wiggle your toes? Good. See ya.
I saw 8 patients and I spent an hour with each one. Like our days are just very different. So, but you know, so anyway, I hope that I've given you guys a good impression of this work. I love my job. It's there's nothing else I would rather do with my time. You know, this is my passion. And I think for many people who work in this field, it's really a passion. It's a calling. It's not a job. You know, this is our life's work. And we love it. So I hope that some people maybe listening are starting to get that twinkle in their eyes that this is their life's work. If so, you can definitely share my email address, Ryan, and, you know, let people can feel free to reach out to me if they have other questions.
Will do.
Yeah.
Thank you so much.
It was my
Dr.
pleasure.
Julie Krystal,
My
NYMC.
pleasure.
We should share. I'm going to share this with the NYMC
You should.
PR team.
You should. No,
the
you
NYMC
should.
grads
You totally
rocking it.
should. All right.
Thank you so much.
Take
I
care,
appreciate
everybody.
you. Have a good night, everyone.
Bye-bye.